straighter and a little more frizzy. So my texture changed, my base changed. And so today I was like, I'll wear my hair straight. Usually I wear it wavy, but it's like I have to curl it. It's no longer wavy on its own.
Those darn hormones really change everything, don't they?
They do. They absolutely do. How are you doing?
I'm doing well. I'm very excited to have you on. I just hit record because I like to catch everything.
Yeah.
Craig said that your presentation in Vegas was fascinating and I had to have you on. So
thank you, Craig.
I do a lot of interviews, but I will take some time away from the beach to totally interview you because I always have adored you and your message is awesome. But maybe you want to tell people about like how you got into this area and the ketogenic diet?
Yeah. So, I mean, I'm a traditional trained allopathic nurse practitioner. I spent 20 years in ER medicine and cardiology. And 10 years ago, honest to God, 10 years ago on April 1st, so like literally just had an anniversary, I was so frustrated with the lack of emphasis on lifestyle as medicine. And so it's really hard to work in cardiology and not be writing hundreds and hundreds of scripts a week because that is like the traditional allopathic model. And I took this massive leap of faith and, my husband thought I was having a midlife crisis. My friends thought I had lost my mind. And I just kept saying, I know that I will be successful, whatever it is that I do next. And so I kind of created group programs and one-on-one programs for women in perimenopause and menopause because I felt like no one prepared me for middle age, like zero, not my nurse midwife, not my mom, not my, my friends. I mean, none of us talked about it. It was so like taboo. And even in my training, like arguably I trained at an incredible research institution and there was no discussion on perimenopause, and menopause was probably 2 sentences of my education. So I felt like if I really didn't know what to anticipate, then my patients couldn't either. And so along the way, I loved intermittent fasting and, I was very much tucked away in that paleo model. So I went gluten-free, I went dairy-free, I went grain-free. And that was, where I hovered for a really long time. And so I've neatly been tucked away in the perimenopause and menopause space for 10 years. Went on to do a couple TED Talks. My first one was actually on perimenopause. Not a lot of people know that. The irony being that in 2018, there were 4 talks on menopause. And because there were no talks on perimenopause, they let me do one on perimenopause. And so that I went on to do a second and then, led to a book deal and just have had a really incredible opportunity being able to help and impact, millions and millions of people. So I sit back and very humbly say like how grateful I am that the trajectory has taken me like really very much full circle into, being able to impact more people than if I were just in an office. And this is not demeaning anyone that does hospital medicine or works in a clinic because I did both for many years. I just felt like my message and what the impact of my work needed to be bigger than seeing, 16 patients a day in the clinic or however many I saw in the hospital, depending on the acuity of how sick people were. And there are things that I miss occasionally about traditional allopathic medicine, but generally speaking, I think things have gotten harder and harder for my colleagues over the past 10 years. And so I always say, like, with tremendous gratitude, I've been able to build a business really surrounding and helping women find their voice, feel empowered, and be able to make better decisions, educated decisions for themselves, and really all about advocacy. Because in a very paternalistic system, a lot of women feel incredibly lost. There was a podcast interview I had a couple years ago, and this male physician said, Cynthia, if men were treated the way women were in the medical system, they would never put up with it. And that stayed with me. It really stayed with me, realizing how much women put up with that is not necessarily acceptable.
Right. We just finished a book and I wrote about hormones because that's probably why I adore you so much, is because I grew up with PCOS. I always had these really weird hormones and cycles, and the doctors were like, that's just you. And I'm really upset because I feel my whole body, I mean, did I have bone loss? Did I have all these issues because of my hormones? But in the hormone chapter, I wrote about how, you know what, if men were dealing with like shriveling up penises and all of this, healthcare would be all over it. They would be helping them so much. But the fact that it's happening to women, it's it's such a sad moment for women. And is it true that only 5% of women are on HRT post-menopause?
That's the current estimate, but that only takes into account pharmaceutical made drugs. So in a pharmaceutical drug company, I think that doesn't necessarily take into account compounded drugs, but it is still very low.
Yeah.
And that has a lot to do with, what happened with the Women's Health Initiative. And it's also, transparently, I think it's still clinicians being hesitant to prescribe hormone therapy appropriately. And then you have a whole generation of women. Like, I came out of my nurse practitioner program in 2001. I was young. I was in my 20s. And I recall in 2002, because I would have patients come through cardiology clinic or in the hospital, and they would say how miserable they were being off of hormones. So I was really part of that generation that was taught hormones are bad. Hormones cause cancer, therefore do not prescribe hormones. Now, thankfully, there were a lot of my colleagues who did not listen to the WHI and were still continuing to support women. But my mother's generation, the boomers, are the ones that are living with the side effects of going without hormones for 25, 30 plus years. And it doesn't have to be that way. I think it's so imperative that we're having these conversations and helping women know that they have options. Like, maybe HRT isn't your choice, and someone that's listening says that wasn't the right decision for me. That's great, as long as you have fully informed consent and someone has sat you down and said, here are the benefits.
Right.
Here are the things that can potentially happen if you're not replenishing those hormones. And if they make that decision, I respect that. But
my mom is 78 and she listens to nothing I say about diet. However, because I'm doing interviews like this, she was part of the WHI. I think she was taken off her hormones at 65 or something. But now that she's 78, she went back on it and she feels like $1 million.
Good for her.
So
my mom is 80. And I think my mom has been like hesitant. Like, she's on vaginal estrogen. I got her to at least buy into that. But I was like, how do you sleep, Mom? Like, I can't even fathom what your sleep quality is like. And I think a lot of those people just toughed it out. Like, they were like, I don't have any hormones and I'm just going to figure it out. And I don't know, it can't be, I think from my perspective, knowing what I know now, I just think the more that I understand about the physiology of our bodies as our hormones are declining, the more I'm like, oh, this isn't optimal. Like, is it normal to go into menopause? Yes, if you live long enough. Is it optimal without hormones? No, not at all.
It's not. I like my mom, she said she played 3 rounds of pickleball yesterday. And I'm so proud of her for how active she is. But
amazing.
What's really frustrating is a lot of people say, well, I want to back up and go into like what happens without hormones and the microbiome and all that. But this idea that our ancient civilizations didn't use HRT, like this is some new phenomenon. It's like I just was at that new Egyptian museum in Cairo, or was in Giza. They actually had HRT for women. They used adaptogens, herbs, tinctures, all the things, even way back then. So this is not a new phenomenon. They knew that when their hormones decline, they feel worse. Different.
Yeah. And I think it's important for people to know that it was the standard of care up until the WHI. And I think that, we could make the argument that, maybe people didn't live to menopause. That may be true. I think people are living longer. There's no question. 150 years ago, people probably didn't make it to 51. That's the average age of menopause. However, I think that to acknowledge in an absence of hormones that you don't need additional support of some capacity, to your point about the Egyptians, clearly people were acknowledging that things were changing and that, whether it was sleep or mood or libido or any number of symptoms, men go through andropause. It's just not nearly as dramatic. Like, they have a slow kind of steady decline in testosterone. And we could unpack why that might be worse for some men versus others. But I think for a lot of individuals, it's like women literally kind of go through this rapid kind of decline and then they drop off a cliff. Like, it is dramatic. It is significant. And in many ways, we are so protected from things like cardiovascular disease until we go into menopause because of the changes that are happening at a cellular level. It's not this seemingly benign entity. And I think the other thing that I find fascinating is that there are a lot of people in the perimenopause, menopause space that just focus on 3 things: bone, brain, heart. And they don't think that these are systemic hormones. The side effects of the decline in hormones impacts neurotransmitters. It impacts every cell in the body. And for people to think it's just literally three buckets of areas of the body that are impacted is unfortunate, because you really want to think about your hormones as this incredible symphony. And if the symphony is not playing properly, if it's off key, or, the oboe player has, taken a siesta, or the drums are too loud. I mean, however you want to make the analogy about it, our bodies are designed to have a very orchestrated way in which our hormones work together. And this is definitely a time north of 35 for many women. As a woman who had PCOS, you probably had lower levels of progesterone to start with. So you might have had more magnification of symptoms than maybe someone else who didn't get symptoms until they were in their mid-40s. And so I think there's very much a bio-individual approach. And I think for every woman listening, it's just, getting the pros and cons of all your choices and options, and knowing that you don't have to suffer. I think that's a huge kind of prevailing theme, is suffering is definitely optional and not mandatory.
Well, okay, let's say a woman is not suffering. They don't have sleep issues. They don't have hot flashes. They don't have mood changes, or so they feel. Why should they still consider HRT?
Yeah. Well, I mean, at a very basic level, there's something called genitourinary syndrome of menopause, as unpleasant as that is called. And what it's really speaking to is that as your estrogen levels are declining, there's a very specific pH, just like pH levels all throughout the body. There's a specific pH level in the vagina, not surprisingly. And as the pH levels increase, you die. The beneficial bacteria, lactobacilli, et cetera, that create mucus, that lubricate the vagina and do a variety of other things, they decline. And as they decline, it makes you more susceptible to infections, painful sex. It impacts the integrity of your pelvic floor. It impacts how frequently you go to the bathroom. And so it's not a question of if, but when. So when a woman says to me, I feel great, I'm 55, I'm 60, I don't feel any ill effects, I don't need hormones, statistically, you will eventually develop genitourinary syndrome of menopause. I find in my younger patients that are thinner, younger women are probably going to have more symptoms of genitourinary syndrome of menopause than someone who is perhaps overweight or obese, because there's just more adipose tissue. And adipose tissue can definitely kind of buffer some of these side effects. So number one, what many women don't think about is, yes, a urinary tract infection is pesky, it's bothersome. I may have to pee more frequently in the middle of the night, like nocturia is the technical term, but it shouldn't be normal. Like if you pee in the night once a week, no big deal. But if it's twice a night, frequently at night, that's problematic. Pelvic floor issues, uncomfortable sex, tearing with intercourse. But what people don't think about is a lot of women that are older get urinary tract infections that become systemic. It's called urosepsis. How many little old ladies did I take care of in the hospital or in the ICU that had urosepsis because they were menopausal, they were on no HRT, they were on chronic antibiotics because they had chronic UTIs. And here's the big thing, just the use of vaginal estrogen will decrease hospitalizations by 70%. So when someone says, I don't need HRT, I'm like, you need vaginal estrogen.
Yes.
Everyone needs vaginal estrogen. And I can make the argument everyone needs compounded estrogen with some testosterone or DHEA, because that helps the muscular layer of the vagina, because the vagina is like one big muscular tube. I think the other things that I think about, HRT, specifically estradiol, is primary prevention for osteoporosis. Now, people think about bones like bones are just like a structural thing. No, they're living tissue. And so I remind people that as we are losing muscle, we are also losing bone. This accelerates in the loss of hormones. And so what many people do not know is that osteoporosis in most instances is completely preventable. And what people don't think about is that, that first hip fracture or a frailty fracture, so you trip and break your wrist, you trip and break your ankle, you trip and break your arm, that's a poor prognostic indicator. Like sometimes accidents just happen. Let me be very clear. Like you could be the fittest, most healthy person and accidents happen. But I'm talking about people that fracture a hip, 25% of them will never go back to living independently.
Right.
That's significant. So those frailty fractures are not benign. And for a lot of women, they start in their late 50s, they start in their 60s. I don't know about you, but one of my greatest concerns in life is maintaining independence. And what people don't realize is as you're losing bone, as you're losing muscle, you get closer and closer to frailty. Frailty is what leads to falls. Falls lead to a loss of independence. And so it's hard when you're in your 40s and 50s to wrap your head around that. But I took care of so many of these patients. It happens quickly and kind of insidiously. The other thing is, when I think about heart disease risk, 1 in 3 women, it's not breast cancer that's going to get most of us. It is heart disease. And women present differently. We present with microvessel disease, so not necessarily the stuff that can be stented or bypassed. We present differently. We present later. Sometimes the symptoms aren't shortness of breath and chest pain. It could be like fatigue. I had female patients that were having acute infarcts, so acute heart attacks in the ER, that they had like pain in a hand or pain in their back, like sometimes very non-specific symptoms, or they would have reflux and they would get diagnosed with other things without that clinician realizing. So I want everyone to understand that heart disease is what we want to avoid the most. And what happens in the setting of declining estrogen is that we have more inflammation, more oxidative stress. We get alterations in something called endothelial function. So that is our ability to dilate these arteries and have flexibility in the vascular system. That is a direct reflection of, as estrogen declines, so does nitric oxide. This is a really important signaling molecule. And so people will say, but I'm not having symptoms, or I had a negative CAC, which is this coronary artery calcification exam. That's only looking at hard plaque. Hard plaque is generally not what's going to get us. It's soft plaque. So CT angio or clearly is like AI plus a CT angio. So it's like they had a baby. Yes, it is an out-of-pocket expense, but at least a CT angio, because that's looking at soft plaque. That's the plaque that tends to be the stuff that breaks off and occludes an artery. And so I think about the role of estrogen and how that declines. So that's sometimes that can be the silent killer for a lot of people, or the silent, kind of brewing beneath the surface. I feel good, therefore I don't have a problem. The other thing is, we have evolving research on brain health, and Dr. Lisa Mosconi is a neuroscientist. She's at Cornell. She's doing incredible work on reducing the risk of Alzheimer's. Her goal is to reduce it by 50% because women generally outnumber men being diagnosed with Alzheimer's. And we also believe that our brains are protected until we go into menopause. So what many people don't know is our brains in our 40s and 50s set us up for 60s, 70s, and beyond. So really critically important that we're maintaining metabolic health in middle age. Like, it's not just I want to fit in my skinny jeans thing. It is really like your metabolic health is going to set you up for success, or it can be a prelude to further issues, further down the road. So when I think about on a kind of macro level, those are 3 areas that the research is very solid. The other thing is the gut microbiome is evolving. So the research, as I was writing the book, The Menopause Gut, was talking about if we look at a pre-perimenopausal woman's gut microbiome versus perimenopause versus menopause, if you give a woman hormone replacement therapy, their microbiome can look like a younger woman's. And we're not talking like the superficial stuff, like I don't want to have wrinkles. We're talking at a deep cellular level, because a lot of what impacts how we age is the aging of our immune system. And I know it seems a little intangible because people are like, I don't even know where the gut microbiome is, let alone what the immune system is doing, because it's not tangible like so many other body systems are. But I remind women all the time that the microbiome is oftentimes the missing link for their health. Like I jokingly say, but I mean it, if you think just slapping on an estrogen patch is going to fix all your problems in middle age, I'm here to tell you it's a much more nuanced conversation. It doesn't mean hormones aren't important. They are. I do think they are. But it's a much larger conversation that involves really looking thoughtfully at the gut microbiome, because the gut microbiome really is the intersection for every body system. Like there's a gut bone axis, a gut brain axis, a gut ovarian axis. And I think for a lot of people, because it's not tangible, they can't see it. It's helpful for them to know, like, what is that? It's 40 trillion bacteria, viruses, fungi, and protozoa in the large intestine or colon. And it's like a little communication system. It communicates with every organ, every cell in the body. Obviously, when I went through all my training, we didn't know what it was. It's really been the last 5 to 10 years. And in all the conversations I have on the podcast, I would have guests, and each time a new guest would come on, I would kind of ingest what they said. And I started to realize, like, no one's talking about this, but yet I think it is so important. It's as important as the other great works that other women are doing in the space right now to kind of push the envelope, advocate for women. All of it's important. But I think in many instances, these women, go into perimenopause not understanding that a lot of the good things we were doing when we were younger, whether it was adaptive, you're successful, you whatever career you're in, you're doing well, you marry, you're happy marriage, you have healthy kids, whatever it is that you aspire to do, they get into perimenopause and you just don't cope as well. And it's because your physiology has changed. So your lifestyle now needs to match the changes in your physiology. And for many women, that's hard to do because they've spent a lifetime being successful. They've been able to achieve great things. And all of a sudden it's like, wait, what I mean, you want me to sleep more? You want my stress? What? All of a sudden I have to change my diet? What do you mean? You want me to exercise every day? Because I grew up in the 70s and 80s. And so we were conditioned to believe you want to be skinny and fat is bad. Two kind of prevailing themes that I think are problematic for different reasons. But you come out of that with a very different perception of strength training and working out. And I would then layer in this gut combination because like things as simple as, I don't know if you know this, Maria, but if someone experiences a lot of stress and trauma as a child, that imprints your nervous system. That can contribute to when a woman goes into menopause because chronic stress activation is not per se a good thing. Like right now, if you were to measure my cortisol levels, I'm sure they're up because I have lights on, I'm engaged, I'm having a conversation, I'm thinking, I'm excited to be having a conversation with you. But like that is very different than chronic unrelenting stress, which I would argue male or female, young or old, is destructive over time. And so I think for a lot of individuals, perimenopause is a litmus test for how well you take care of yourself. And that is tough to hear. It's tough to hear. And it's hard for a lot of women to change to course correct and change the way they've been living their lives. Because they generally, by that point, they think they're doing a pretty good job.
Well, there's so many things to unpack with that part that you talked about, but I want to back up to the vaginal estrogen thing. I have a close friend who, whenever we would laugh all the time and have a good time, and she's like, "Stop! Don't make me laugh anymore," because she would.
Oh yeah, she's incontinent.
And I said, "You need some vaginal estrogen," and guess what? She got on it, and it's no longer an issue. It helps strengthen that. Obviously, it's not an overnight fix,
right?
But I saw a statistic that we would save over $6 billion a year in healthcare if we would just prescribe vaginal estrogen.
Yeah. I mean, 70% reduction in hospitalization. So I think that is staggering. And I can't tell you, Maria, how many middle-aged and older women, like I would go through their chart and I'm like, why are you taking XYZ antibiotic? Really low dose. Oh, because if I stop it, I get a UTI. And I'm like, that's decimating your microbiome. Not to mention women are 4 to 5 times more likely to develop autoimmune conditions in middle age. It's like, it just creates the perfect domino effect. So I'm so glad that your girlfriend took your recommendation because no one should have to suffer with being incontinent. I mean, that's, it's funny. I had 2 breech kids. I had 2 C-sections because I had such big breech kids. There's no turning them around. And I recall saying to someone, oh, because I didn't have vaginal deliveries, I would imagine I'll never have pelvic floor issues. And actually, my pelvic floor specialist was saying to me, that is a common misconception. People assume there are so many factors that impact the pelvic floor, but most people don't even know how to properly engage their pelvic floor because there's, stigmatization around the pelvic floor area anyway. But it's also, unlike other countries like in France, as soon as you have a delivery, you go to pelvic floor therapy. Whereas here you have to, generally most of my patients are begging for it before they get the referrals that they need. So I'm so glad that your friend took your advice and feels better.
Well, I asked a lot of questions on my private Facebook group. Hey, I'm interviewing you. And one of the questions was, what helps with vaginal dryness? I am already on estradiol and progesterone compounded. And I'm like, hello, vaginal estrogen. But that's the answer, right? I mean,
and that's like not every woman who is taking transdermal estrogen necessarily needs vaginal estrogen, but eventually you will. And so I think the painful sex piece, it's like clearly your vagina has now become the Sahara Desert. And so I think for a lot of these women, it's so validating to know there's a treatment. It's like, oh my gosh. The other thing is, I think it was Dr. Rachel Rubin was talking about how in the absence of hormones, some of the anatomy will change significantly. And so women were like, oh my God, I'm going to lose my outer lips of my vagina. Like, what are you talking about? So yeah, you need vaginal estrogen stat. It is inexpensive, easy to use. I think it is, if you have gone a long time without vaginal estrogen, sometimes people have to be careful because it can be irritating. Like as you're trying to replenish not only the lactobacilli and reestablish, some of the moisture and flexibility of those tissues. If you're really, really depleted, you may have to like go at lower doses just because your skin can be really friable.
Well, I don't know if I should open up here, but I'm getting up there in age and I would have at least 6 UTIs a year.
Oh, you poor thing.
And they would just always, I knew exactly what antibiotic would work. And I was in Bali and I had to go to the pharmacy, and in other countries, it's easy to get. I was in Italy, I had to get it. I mean, it's usually when I traveled because, whatever excuse I had. But I finally found a doctor in Hawaii that was like, you need vaginal estrogen. And I've never had one since.
Amazing.
It was life-changing because it would like ruin a trip, right? I mean, it's just very uncomfortable. And I actually now put it on my face too.
Well, I was going to say, I have compounded, it's estradiol, estriol, DHEA, hyaluronic acid, and copper peptides. And I was saying to someone, you can get that compounded. You can't buy it over the counter. But I mean, I'd rather use that than some of these disproven things that are out there. The other thing that I think is interesting, Maria, is that vaginal estrogen is not just for menopausal women. Like women that are taking birth control, sometimes it lowers your estrogen enough that you have those same symptoms. Even women who are breastfeeding, because it's localized to the vagina, it's safe to do that. But I think for a lot of women, like understanding, like you can be on contraceptives and need it. You may be breastfeeding and need it because you're in a low estrogen state. So it's not just middle-aged women. I think a lot of women can benefit, and we need to destigmatize it so that women get the help they need.
Well, I know a lot of doctors are anti-HRT if somebody had past breast cancer, because that's one of the questions. And my suggestion is I'd rather have quality of life over quantity. That's just me, but at least get on a vaginal estrogen.
Well, and it's interesting. I did a podcast with Dr. Avram Bluming and Dr. Carol Tabor. So he's a medical doctor, oncologist. She's a researcher. They wrote an amazing book called Estrogen Matters. Highly recommended. His wife had breast cancer and his daughter. They're both on HRT. So it is old school. I would also recommend Dr. Corinne Men, who is a breast cancer thriver and takes HRT and prescribes it. Right. So it is old school if someone's telling you cannot take HRT because you've had cancer.
Well, and here's the thing. Doctors are so fast to prescribe an oral birth control and oral estrogen, which has its issues with like raising sex hormone binding globulin and all that. But a topical, like a cream, a patch, an injection, is totally different. It's a totally different method.
Yes. Yes. And I mean, there are people that benefit from like oral estradiol therapy. Sometimes there are women who just cannot get enough absorption of estrogen through their skin. And obviously anything.
Would an injection help though? What about an injection?
I don't necessarily love estrogen as an injection. I think that, I would say standard of care is transdermal. So skin absorbed is a starting point. Oral estradiol is bioidentical, not the like birth control version of estrogen. But for some people that they can't get their numbers therapeutic through the skin, sometimes we'll prescribe it orally, plus or minus, people that have specific like LP little a, I don't know how much your community knows about this risk factor. It's 7 to 8 times more atherogenic than other lipid markers that we look at. But for some of these people, we know that estrogen can be a weak, and I'm going to use a big fancy word, PCSK9 inhibitor, which is one of the drugs we use to treat, I don't prescribe these drugs. Repatha, they are what is clinically indicated to drop LP little a. But estrogen can also be a weak PCSK9 inhibitor that is also better tolerated. But anytime you take a drug orally, you get a first pass effect in the liver, but at very low doses orally, I think oral estradiol therapy can be an option for women. Obviously, there's more risk factors when you ingest a drug than if you absorb it through the skin. So it always has to be in the context of having a larger conversation. Like just like if you take oral contraceptives, if you're on the pill, when you ingest a medication, it increases your risk for certain things. It doesn't mean it will happen, but I think it's still like a very minute amount of people, because now the oral contraceptives are much lower than they were when the pill was invented in the 1960s. So much less likely to see people getting blood clots and things like that.
What about a sublingual estradiol?
So you're talking about a troche.
Yep.
Yeah. So I have colleagues that really like them. I think that number one, we're all bio individuals. Number two, there's different routes of administration and it's the comfort level of the prescriber. I just have done really well with transdermal options, rarely needing to prescribe oral estradiol therapy. I just like predictability. And sometimes with a troche, depending on the compounding pharmacy, depending on the individual. But my feeling is I have colleagues that love troches. So I think if that's working for someone, I think that's great. But I would say when we talk about injectable medications, usually we talk about oral progesterone. Usually we talk about transdermal estrogen. I'm saying usually, that's like the majority. Transdermal testosterone versus subcutaneous. I think most people would say like subcutaneous is usually reserved for people who can't get their levels where they need to be. And not every clinician checks levels. So that's also another like confounding issue. Like
mine does every 6 months. Jeez.
Which I think is great. I think for a lot of people, like I know where I like my testosterone numbers to be, where I feel good clinically. Yep. But I think there are just as many providers that are like, I don't need to test it. You're already taking it. It's fine. But we know. Sorry.
No, sorry about that. I was just going to say, so when I get mine tested, and it's usually very, very high testosterone. However, I also have a very high sex hormone binding globulin. Can you tell people what that is, why that matters?
Yeah. So sometimes people with PCOS have high testosterone. And when we're talking about high testosterone, I've seen levels, total in the 300s. I think the concern is always, number one, are you symptomatic? Like sometimes people, when a woman's testosterone is high, she can develop hirsutism. She can have hair in inappropriate places. She might get acne. Her libido may be beyond where she wants it to be. And I think libido is very subjective. Now, sometimes someone's testosterone is high because they are on pellets and it's super physiologic high. That's different than what
Maria's. Recommend that, right? I mean, we're not recommending that.
Yeah. And I just want to qualify that, because when your testosterone is too high, you can worry about having heart attacks and things like that. And I have a lot of colleagues who have talked to me, have shared with me privately about patients of theirs that are young, late 30s, early 40s, that have gotten pellets and have had heart attacks. So that's, yes. So there's that issue. Sometimes.
What doctor's prescribing it at 30?
Yes.
Okay.
So there's that. So sex hormone binding globulin is kind of like a catcher's mitt. It's kind of designed, it's all about balance, but when someone's sex hormone binding globulin can be high, sometimes the bioavailability of the hormone is diminished. And so it's always in context of the patient and what their other hormones are doing. Now, when you're working with patients, sometimes ideally you want to test estrogen on day 3 and you want to look at progesterone on day 19 through 21, or you want to look at testosterone at any particular point. It really depends on the individual. So sex hormone binding globulin is taken in the context of what are the other hormones doing. For some people, it buffers their hormones enough they don't feel like they're taking hormones. And that's the significant piece, that it's always in the context of what are the patient's symptoms? How do they feel? Now, sometimes when people are taking, this is a shame, but take oral contraceptives to prevent pregnancy, and then their sex hormone binding globulin goes up. So it's almost like they have no hormones available. And it explains why many women on oral contraceptives are like, this is great. I'm not going to get pregnant, but now I have no libido. So there is very much a bio-individual approach to this. I think that it's always in the context of what is normal for you. And the other thing, Maria, that's interesting is not every woman in menopause needs HRT for testosterone. About 25% of women continue making enough into menopause, which is great. Unfortunately, I'm not one of them, but there are women that are out there that are like, oh, this is fantastic. Like there was a instructor I had in a functional medicine course, and she's like, yeah, I'm 75 and I don't need testosterone. I'm like, good for you. That's one less thing to worry about.
Well, my free testosterone is definitely in the normal range. It was just my total was really high. But I have so many questions going on here. So you mentioned the microbiome.
Yep.
What does a poor microbiome impact? Does it impact sleep? Does it impact, you mentioned the skin?
Everything. So think about it this way. There are many things that impact the health of the microbiome. Our microbiome is imprinted by how we are delivered, vaginal or C-section. It's imprinted by whether we are breastfed or formula fed. And let's be clear, we have no control over that. Like what's happened in the past has happened. There's a next big kind of bump in the microbiome diversity, inflammatory species, et cetera, in puberty. Both young men and young girls are heavily influenced by hormones, the hormones that we're talking about, testosterone, estrogen, progesterone. The next potential big kind of time in a woman's life that can be impacting their microbiome is during pregnancy. Not surprisingly, of very high levels of hormones, and then perimenopause, when we're seeing hormones for the most part declining. And so what's really interesting to me is there's that piece, and then there's also superimposed with it, what's our stress levels like? What types of toxins are we exposed to? Are we on synthetic hormones? Because we do know there's a net impact of synthetic hormones on the microbiome. Do we drink alcohol? Do we smoke? Are we consuming produce that's infiltrated by glyphosate, which we know can be a chelator? There's a lot of things that happen with glyphosate. So toxins we're exposed to, chronic stress, antibiotics, all these things can impact the microbiome. So for everyone that's listening, we probably all have a slightly different composition to the microbiome. And what's interesting is, as women are navigating this decline in hormones, the microbiome responds accordingly. So estrogen in particular is the one that we know the most about. As estrogen's declining, we're seeing more propensity for leaky gut. So people hear leaky gut, what does that mean? That means that if you think about the small intestinal lining, which is one cell layer thick, as like a brick and mortar system, as estrogen declines, it's the mortar. So the mortar opens up and you are more likely to leak food particles into the bloodstream. You're more likely to provoke an immune response. Women are 4 to 5 times more likely to be diagnosed with an autoimmune condition in middle age. So that's quite significant. When I finished my training, there were probably 20 to 30 autoimmune conditions. Now there are over 100, including things like chronic Lyme, long haul COVID, et cetera. So it is quite significant. The other thing is that immune system ages right along with us. It's actually one of the key kind of hallmarks of aging, that as the immune system's aging, it changes how we respond to opportunistic infections. It changes our response to vaccines. And I don't state this to sound political at all. It's just that is what the research shows. It's why when you go to CVS, I'll use CVS as the example, they offer you a shingles vaccine, a pneumonia vaccine, and a flu vaccine. And it's because our immune system becomes a little less responsive. So we know that our immune system starts to falter and can make us more inflammatory. It also makes us more susceptible to food allergies, histamine responses. A lot of women will say, I'm middle-aged and all of a sudden I'm seemingly much more reactive to certain foods. Part of that could be what I talked about, where you leak food particles into your bloodstream. But the other side of it is you have a cranky immune system. Your immune system is much more reactive. So in the setting of estrogen fluctuates 20 to 30% throughout perimenopause. We can sometimes have the highest levels of estrogen of our entire lives. When estrogen is high, we are more likely to get a histamine response. We can trigger mast cell degranulation, and women will say, I developed food allergies, plus or minus, I develop hives. I'm much more reactive to foods. And that is a byproduct in that high estrogen state. And it's also
when it's falling.
I mean, it can be multiple things, but typically it's in the setting of high estrogen, estradiol. And so for people, it's very, very frustrating to try to navigate what are all the things that are changing, not to mention motility changes, because as progesterone declines, that's a smooth muscle relaxant. Women get more reflux. They may feel like food sits in their stomach longer. As estrogen declines, like I mentioned, it impacts nitric oxide signaling. So food may not move through as quickly. We might have less hydrochloric acid, so we don't break down protein as readily into amino acids to be absorbed. We don't make as many digestive enzymes. Fun fact about estrogen is that bile, which is designed to break down and emulsify fats,
So important.
estrogen declines, we don't digest our fats quite as well. So certain types of testing we can look at to see, do you need additional support just to be able to support breaking down fatty acids? So to me, it is fascinating, all the things that change in the microbiome. But for a lot of women, it really speaks to all the symptoms, the bloating, the bowel alterations. Like suddenly they're told they have IBS, like, oh, you have all this constipation and this diarrhea, or alternating bouts of both, or you just overall feel like you don't digest food well anymore. Those can be like life-changing things that happen. And yet all the focus is on, let me be clear. It's important to talk about heart disease risks, bone health, brain health, but equally important is the gut, because it is the main site for impacting metabolic health, which I'm sure your community is super savvy about. I remind people all the time, as we're losing muscle, as we're losing estrogen, we're losing insulin sensitivity. And I think for a lot of people, they don't understand their relationships with macronutrients have to change. Like more protein, quality of carbohydrates becomes important. Even if you're eating a small amount of carbohydrates, it's not the bread and pasta for most people. It is really getting some fiber into your diet, which I know can be controversial with some of my keto friends, but I explain why. We stop making as many short chain fatty acids. These are important because they reduce inflammation. They're important for mucus production throughout our digestive tract, which sounds gross, but it's important because it's protective. They impact GLP-1, endogenous GLP-1. I know those drugs are very popular right now. Endogenous GLP-1 regulation, so satiety hormones. And as we have less hormones, we're making less short-chain fatty acids. That's why fiber becomes important. It doesn't mean that everyone has to be eating, the targets of 25 to 30 grams a day, but it's why we need to be conscientious about that. Because the one thing that I know, I just finished interviewing a microbiome researcher, and she was talking about a study and said, this particular study, if someone in the absence of absolutely no fiber, your body will try to ferment protein. And as you can imagine, that has, putrefaction is not the goal. Like we want to be able to break down it into amino acids and process it. But it was interesting that she said, she gets concerned when people say, I don't, all carbs are bad, no carbs whatsoever, no fiber at all. She's like, it's interesting how the body responds to that. And so she was talking to me about that research. And I was like, that's really interesting.
Well, that, and on top of the gluconeogenesis, which it's going to use some of the protein that you're eating for glucose, because your brain needs glucose, your thyroid needs glucose. So I went carnivore for a few years because Craig had chronic Lyme disease and all these issues. And it was the only thing that took his pain away. And just as a family, we just supported the dude.
Sure.
And learned a lot about oxalates and things like that. I still don't eat vegetables that much, but I do have a lot of fruit, and I feel like I am so much healthier. My blood markers are so much better. My skin is so much better. And so I don't think, everybody's like, carnivore is the best thing ever. And first of all, carnivore did not heal my husband. It did not. It took his pain away. However, I don't know. I'm just going off on a little tangent there.
No, but it's interesting. I always transparently, and I talk about it in the book, that when I was hospitalized in 2019 and spent 6 weeks on antibiotics, and let me be clear, I almost died. There was no other way. I did that second TED Talk with a ruptured appendix. I tell people my gut was decimated, but it saved my life. So there is that part of it. But for 9 months, I could only eat cooked meat. Like I could not tolerate any fiber, any vegetables, any fruit, nothing. And I remember saying to my GI doc, are you concerned about the fact that I get diarrhea, like if I eat anything other than meat? And she said, no, eventually it'll figure itself out. So for 9 months of my life, I was full carnivore because I had to be, and it's taken a long time. Now we're talking 7 years later. And I kind of look at it as it's probably going to take the rest of my lifetime to rebuild that microbiome, because it was just decimated in the setting of trying to kill off an infection that was trying to kill me.
I'm not sure if you're familiar with the Mary Ruddock, but I did an interview with her, and she said, carnivore is a tool. Yes. But the ultimate goal isn't to stay on carnivore. And even our ancestors, if they walked by a strawberry patch, they weren't like, I'm a carnivore, I don't eat that. Right? They were opportunistic. And so the goal is to heal your body so you
Mhm.
can incorporate more things.
Yeah, I agree 100%. And I tell people all the time, like I've had to be getting colonoscopies every 5 years since I was in my 30s because I have a bad family history.
All right, we're jumping back in. Sorry about that.
That's okay.
I'm going to ask, so you mentioned sex hormone binding globulin and birth control can raise that. But I also was told the healthier you are, the higher it can go. And people with pre-diabetes or type 2 diabetes usually have a low sex hormone binding globulin, which seems counterintuitive. Can you explain this?
I mean, I actually have never heard that before, and it's not a test that I'm drawing with any regularity. And I would love to be able to make a conjectured supposition, but there's other markers I look at that will show me if someone has like poor mitochondrial function, like sometimes really low fasting insulin, really low uric acid. Sometimes it seems counterintuitive, but when I'm thinking about mitochondrial health, I have not read anything that lower is necessarily bad. There's very much a Goldilocks effect for sex hormone binding globulin, but I haven't actually heard that.
Okay. Just an interesting little thing. Thoughts on cycling progesterone 14 days on and 14 days off for optimal health? That was a question that came in.
Did they specify if they're in perimenopause, menopause?
Well, I'm guessing peri, because why would you cycle? Not.
Yeah. Well, it's interesting because there's a lot of, or there's a lack of consensus about cycling hormones in menopause. That's why I was getting clarity. Typically we start with, we'll do progesterone a week or 2 weeks out of the month. So usually in that luteal phase prior to menstruation. I think that's completely reasonable because at the very beginning of perimenopause, you might not need progesterone more than where you would normally have it in your cycle. So a week or two of the month, I think is completely reasonable. Typically in patients that are farther into perimenopause or even menopause, usually we have a 1-day break once a week. So, you take it every day of the week and then you skip Friday or Saturday night, wherever you think it's going to have least impact on your
sleep. Well, like what if you still sleep terribly? Can you do it for the, more than 14 days on, 14 days off?
Yeah. I mean, I think it's always taken in the context. If someone's not sleeping well in perimenopause, the question is why? And generally when people don't sleep well, it's because they're not managing their stress. It can also be gut health, which is, again, why I go back to that. It can be underlying trauma, adverse childhood events. I think it really, in that setting of a decline in hormones as well as neurotransmitters, I think a lot of mental health stuff can come up. And I say that very respectfully as someone that believes that, if someone needs an antidepressant or an anti-anxiety agent along with HRT, there's zero shame in that. But I think that that's not talked about enough. It's kind of the prevailing thought processes, antidepressants, anti-anxiety agents, and in some instances, someone just needs more hormones, quite transparently.
What are the long-term negative effects of oral progesterone? That was another question. Are there any?
I think that there are people that tolerate progesterone better than others. Some people are sensitive, and so you can change routes of administration. Like some people, instead of taking it orally, they will take it rectally or vaginally. That's always in context with the conversation with their prescriber. But some people are very sensitive to progesterone. Sometimes it's dosage related, like out of the gate, sometimes people get 200 milligrams of progesterone and they do better on compounded 50 milligrams. So I think a lot of it is bioindividuality, how people respond to it, and then different routes of administration. Because frankly, if you think about it, if you use vaginal progesterone, it's closer to your uterus. So for people that need uterine protection because they're also taking estrogen, sometimes that can be better. But what a lot of people like is they like the sedating effect of progesterone. So that can be why sometimes people will struggle with that decision. They're like, wait, I like the fact it makes me feel tired. And that's what there's a metabolite called allopregnenolone that gets upregulated when you take oral progesterone. And for me, I have to know that I take my progesterone right before I go to sleep because I know that I will fall asleep in about 15 minutes.
Yeah. I was still having some sleep issues this past summer. And I had my girlfriends over and they're nurses and they said, just increase your dose, just see what happens. So I went to 400 milligrams. I took 2 and my breast started hurting. And I was like, that's not why I'm not sleeping. It was a lot of stress and other things going on. So just being aware of that. But lots of questions here. What do you think about, you mentioned estradiol a lot. How do you feel about bias? Because I get that question a lot. And I'm not even going to say what my feelings are. I'm just going to let you go.
Yeah. I mean, I think that there are strong opinions on this. I know that Biest is using estradiol and estriol, so it's a weaker form of estrogen. Now, I think it's fine to use estriol, estradiol, plus or minus DHEA or testosterone intravaginally because they work a little differently. I don't per se think that the research certainly suggests at this point that you need to have a weaker form of estrogen in conjunction with your transdermal estradiol. It's interesting because I've had some very vibrant conversations with guests on the podcast as well as with my own prescriber. And there was a long period of time where everyone was believing that you needed to have estriol with estradiol, depending on, if you're still in peri, then you have more estradiol. If you're in menopause, you need more estriol. And I just don't think that is holding up. I think we're seeing that we're getting most of the benefits from estradiol. I think estriol is fine if you're using it topically. So
Right.
whether either on your skin, like your face, or your vaginal vault. That's a terrible term, but like your vagina. Let's just put it to you that way.
Well,
I hate that term. That's like a lot of times my GYN colleagues are like the vaginal vault. I'm like,
that's
what?
the first time I've ever heard that, but that's funny. Estradiol comes from your ovaries, so that is why you recommend that, correct?
Well, I do because it's the strongest form of estrogen our bodies make up until menopause, and it's certainly the research is demonstrating that is the one that protects bones the best. It's the one that is that weak PCSK9 inhibitor that I mentioned for those that have got high LP little a. And I just think based on everything I've read, and here's the thing, we can always choose to change our minds. Like probably 5 years ago, I might have said Biest or there's even Triest, which is all three main estrogens. But I just don't think there's enough research to show that it's necessarily efficacious to like an estrogen patch is what I'm trying to say.
Well, the problem is too, most Biest is 80% the
Correct.
estriol,
said,
right?
and that's so what's interesting is I have had some colleagues say, well, if a woman's still in perimenopause, we just give them more estradiol. And if they're in postmenopause, we give them more estriol. And I was like, but wait, I don't.
That should be the opposite.
Correct.
Are there suggestions for women in perimenopause who aren't candidates for HRT? Which I would say, why are you not a candidate?
Yeah. I mean, I think sometimes there's situational things. I mean, there's certainly drugs that are out there now that can help with vasomotor symptoms. There are certainly medications that can be helpful for vaginal atrophy, which is, one of the big pain points. There are antidepressants that are used to address vasomotor symptoms. I think that, there are people that maybe are being treated for cancer, might be actively being treated, and it's probably not the right time to initiate hormone therapy. But with that being said, I think that there's lots of options. In fact, I'm technically certified by the North American Menopause Society. And I can tell you that when I took the exam was very little about hormones and more about everything but hormones to prescribe.
Oh, yeah, that's sad.
Which was interesting.
I have a very close family member who went through breast cancer many years ago, and she's on, I don't know if she's still on it, but hormone blocking medications. And now she has
Arimidex. Yeah, that can be brutal. Yeah, they get a lot of bone pain. I've had a couple girlfriends who have been treated for breast cancer, and they put them on those estrogen blockers, and they're real. I mean, imagine you're taking your estrogen to nothing. So brain fog, bone pain, vaginal atrophy. I mean, it's like you take all of the unpleasant side effects of menopause times 1,000. It's really challenging.
Yeah, it is. If I'm in poor metabolic health and menopause and gain belly fat, can I get rid of that belly fat with BHRT or better metabolic health?
Yes. I think it's a twofold thing. It is not just HRT. It is probably lifestyle adjustments, better sleep, manage your stress, protein-centric diet, eating more fiber, doing strength training. The other thing is the research is pretty clear. When we have belly fat, I think she's probably referring to visceral fat. That is inflammatory. That is pathogenic. That is very different than pesky subcutaneous fat, as annoying as that is too. Visceral fat is problematic. So my feeling is probably adding in a GLP-1 is probably a good idea. We know that women that are concurrently taking HRT and a GLP-1 are going to have better body composition. And so for everyone listening, old school thinking is you step on a scale. New school thinking is you do bioimpedance readings so you get a sense of fat-free mass to muscle mass. That is important. And if you're going to consider a GLP-1, you must be eating enough protein and you must be lifting weights. Like those two things should go together. Like before you are allowed to prescribe, well, I can't tell my colleagues how to prescribe, but my feeling is if you are prescribing a GLP-1, you must also be prescribing 100 grams of protein a day and strength training twice a week at a minimum.
Right. The issue comes into play where that weight loss can be a lot of muscle loss. I've had someone come to me and say, a doctor that you and I both know in the keto community has put them on a GLP-1. Their type 2 diabetes got worse because they have less muscle, less places for glucose to go. So if you do this, make sure you work with somebody who's very educated and not just somebody that says, do this.
Yeah, no, I mean, this is important because we also have the other issue, which is, life imitates art. So if you watch any of the award shows, which I do not watch, let me be very clear. But I see the photos and the video. And I will use this as an example. Demi Moore is a very thin woman. Demi Moore, this award season, every photo I saw of her, she looked like a skeleton. And so she's 60 some odd years old. Muscle is so important that when I looked at her, my comment was, because I don't believe in talking about women's bodies. I think that that's not my place to do that. But I said, I see so much frailty. My concern is that frailty will lead to falls will lead to a lack of independence. And I think when we talk about GLP-1s and we talk about appropriate prescribing privileges, we must also talk about the fact that the really, really skinny is in kind of mindset and philosophy. I think we're starting to see an uptick in that again. And my concern is always, like, we want to be strong. Like that's really how we have to be thinking about the conversation. So those body composition readings are important because we can objectively then look and say, do you have enough muscle? Like you need to have enough muscle because that is what's going to allow you to be more insulin sensitive. That's going to allow you to be more independent. It's going to allow you to be able to do things like I travel a lot, and men on airplanes, as chivalrous and nice as it is, can I help you with your bag? Nope.
Yep. I'm good.
I would say, nope, I appreciate that, but I want to do it for myself.
Well, you're right. I mean, I don't know how much you've kept on my journey, but I definitely got too small, and it wasn't, I don't even know if it was super purposeful, but my whole life was out of control. Craig was very sick. We're homeschooling kids, and just the only thing I could control was what I put in my mouth. So I didn't put very much in it. And I got down to 82 pounds.
Oh, Maria, so tiny.
And I ended up in the hospital 3 times.
Wow.
And they didn't really know why. I couldn't move my body. I couldn't walk. I couldn't even feed myself. Craig had to feed me because it was like I was paralyzed, but my mind was there. Mm-hmm. And I was slurring my speech. It was just like everything was shutting down. So now my weight gain journey is also a muscle gain journey. So I stopped running. I didn't miss a day of running in over 22 years. I mean, I would have a flight at 7 a.m. I'd get up at 4 to make sure I had time to run. And so I totally gave up running. I now spend that time strength training. And
good for you.
So
good for you.
I'm trying to get that message out because I didn't think anybody really cared, but the more I talk about it, the more messages I get saying I'm in that same situation. Because seeing that scale go lower and lower was almost like a high, right? Yeah. I knew I looked terrible. I looked really bad. Like living on the beach wearing a bikini, my skin just sagged. I just didn't look good. And so talking about how everything's getting better, like gaining weight, everything's getting better. My energy's better. My skin looks better. My moods are better. So I just want everybody to know, like, skinny is not in, right?
Well, I'm proud of you for sharing your story because I think there's so many women that understand that feeling. I think that, we have extremes. Like we have people that just get more and more diminutive, and then we have people that end up on the opposite end. And so those extremes are never ultimately healthy. But I think the fact that you're incredibly resilient and you've turned things around and you're feeling better, you look amazing, really speaks to the fact that you're in this incredible recovery transition. And I know that people are inspired by you sharing your story.
Thank you. I appreciate it. But like you said, I love that you said you don't judge women or talk about women's body size. I get it all the time. And I recently got back from India, and in India, when everybody's starving, I lost some weight. I'm not going to, consume too much food when everybody else is starving. But anyway, I am off on a tangent. I want to talk more about you. Where can people find you? Where can people find your books? Where can they find your TED Talks?
Yeah, thank you so much for having me, Maria. Always an honor to connect with you. So easiest to go to my website, www.cynthiathurlow.com. The Menopause Gut is currently on pre-sale. It is officially published on April 28th. Oops, that was
nice.
Freudian. Oh my gosh. Yeah, April 28th, but I'm active across social media, probably most active on Instagram. I have an amazing podcast for which you have been a guest on, Everyday Wellness. My new kind of favorite place to be is Substack, because I get to unpack stories in like greater depth. There was a whole story about my childhood, because one of the themes in the book is talking about the impact of chronic stress and adverse childhood events. And so I kind of unpack that, and the whole Substack went viral because people were like, oh my God, I've never told anyone that I went through something very similar. And so I think for a lot of people, it really resonates, because I really believe that perimenopause and menopause, the missing link for most women is this gut health focus, because we can add the hormones back, we can dial in on nutrition, we can lift weights, and we still may not be feeling 100%. And so I really look at the gut microbiome as this missing link in the care that we provide to women in middle age and beyond.
Well, I really love that. And we'll have all of your links below. But one question about that microbiome, is it helpful to take a probiotic and your prebiotics like collagen and stuff?
That's a great question.
It's best to get it with food. Like kimchi.
Yeah, no, I would say fermented foods are like probiotic foods, fermented foods are key, because we have convinced an entire generation of people that they just need another supplement. And if I do diagnostic testing and it's evident someone needs a probiotic, by all means, right? But
that should be short period of time.
Correct. And so I remind people all the time, like, find a couple fermented foods. Like, I like miso. I will have low sugar kombucha. I do non-dairy yogurt because I'm so dairy sensitive. I love fermented vegetables. Like, find a couple things you like and have a little bit with every serving. Like, you don't need copious amounts. Like, when you buy, like at our farmer's market, they always have people that have made, and I refuse. I don't want my kitchen to be a science experiment. So I will buy fermented vegetables or whatever, kraut or whatever it is. And so I will say to people, like, 2 tablespoons. I mean, you don't need tons and tons. I mean, same thing with, I put my coconut milk yogurt in my smoothie. And so it's just like you add it. I have, a third of a cup of low sugar kombucha as I'm going about my day. There's just lots of ways to get these healthy, beneficial bacteria into our guts. And you don't have to spend a ton of money. Like, that's the other thing. Like, I'm not talking about 5 bottles of kombucha a day. I also have women that do that. And I'm like, that's an extreme. Yeah. 1 bottle should last you a couple days.
Probiotics are expensive, but I was just in Korea and they eat kimchi with breakfast, lunch, and dinner, man.
That is a distinctive smell. My husband loves kimchi. He was on antibiotics for 6 months because he got very sick last year, and he's otherwise a healthy person. And my boys and I laugh. I mean, kimchi has such a strong odor. He loves it. And I always tell the kids, don't say anything to your dad. He loves that stuff. So, he opens it up and it's very aromatic, but it's also very good for you.
Yes, it's true. It is. Well, thank you so much for spending the time with us. I know you have a very busy schedule, but I'm very grateful for you.
Absolutely. So nice to be reconnected, Maria. Thank you.
Thanks, everybody. And if you have more questions that we didn't answer, throw them in the comments below, because I'm sure Cynthia would be honored to be back on.
Yeah, absolutely.